All right, everyone. So we'll go ahead and get started on chapter 9. This is lifespan growth and development. Um, if you've ever been to college, this is a course that you typically have to take. It's an entire semester, but anyways, it's a good stuff to know. The overlying theme on this is that we change as we age from neonate to death, right? As an elderly, and we can't just approach each. We can't approach children as small adults, and we can't approach the elderly as the same as someone like me, in my 20s. So you have to approach these patients differently, and they require special considerations and treatments and approaches to how we care for them and treat them. So that's kind of what this chapter is going after. Okay, um, so basically the how this is commonly tested is the book will say like you know what's the definition of a neonate, right? And it's birth to 1 month. And it sounds like really pedantic and like, oh, that's kind of odd. But that's how I've seen this tested traditionally, is they'll ask, what's adolescence? What age would adolescence run in or whatever? That's how these can be asked. Or, what changes would you expect to see in the cardiovascular system in an 88-year-old female? Right? Like, so that's typically how this is asked and examined. Now, and with that, it's also foundational, right? So like, when we run a baby that has been shaken, right? We need to know about, subarachnoid hemorrhage. And if we run, an old person with Alzheimer's disease that falls and hits their head, now has stroke-like symptoms, we might have to think of like a subdural bleed or whatever. So I'm just letting you know there's different presentations of these and how they present. And the age can, what's interesting is a lot of times the age in a vignette, at least definitely in medical school and even in EMT school, can give away the answer sometimes. So always pay attention to the age and like other identifying factors of like if they tell you it's a 47-year-old homeless male, right? Like they're telling you that sometimes for a reason, or if they tell you 88-year-old Asian female, right? There might be some pathology that's more specific to that. So just what I'm saying is pay attention to the demographics and the details in the clinical vignettes of what of like age, sex, race, all those things. If they provide that to you, especially at the EMT level, there's probably some value in what they're telling you on that. So pay attention to that. Now, anyways, an infant is 1 month to 1 year. This is starkly different from a neonate. Okay, so neonates is from birth to 1 month. Okay, so you're going to get a question wrong if you say a 2-week-old is an infant. They're not, right? They're neonates. So be aware of that. If you wonder what neonates look like, here is my adorable nephew. His name is Harvey Harbold. It is my twin brother's baby. He's adorable. I think he's about a week and a half in this picture, and he is a neonate. He's not an infant yet. But yeah, that's pretty much my baby because it's my identical twin brother's baby. So, the vital signs, right? So, at birth, the heart rate, really they say 90 to 205. I'll tell you that, yeah, typically you don't like to see a neonate's heart rate less than 100. I'll say that. But, it kind of depends. How upset is the baby? How traumatic was their birth? How stressed are they? How was their prenatal care? How is mom's health? All these conditions will affect the baby's vital signs, especially at birth. Within the first half hour or 30 minutes, the heart rate will drop down to 120. So the blood pressure will correspond directly to weight. And I wanted to show you something. So I'll tell you this too. I worked at Cook Children's for 2 years in the ER as an advanced care tech, right? So I do have some pediatric experience, so I'll try to give you some nuggets along the way in this lecture. But you can't just put a blood pressure cuff on a neonate's arm. It doesn't work, okay? So what you have to do is you have to see there's an artery running right through here. You have to put that artery line of the blood pressure cuff, the NIBP, the non-invasive blood pressure cuff, the one we use on our LifePak 15 monitors. You have to put that on the infant's like calf and take the blood pressure that way. On this one, they're using an ultrasound probe. Obviously, you don't have that in an ambulance, but you won't need it if you're using a monitor, like a blood pressure machine. It doesn't need this. So it'll do it automatically. So what I'm saying is a lot of times this is how we'll assess blood pressure in neonates, and it's effective. Now, with that, let me tell you this. Okay, let me give you an example. 6-month-old child comes to the ER, shortness of breath, has RSV. It's a respiratory virus, right? Very common in the winter. And you get a blood pressure reading of 180 over 102. Cool. Is it accurate? No. Same scenario, 6-month-old comes to the ER, shortness of breath, RSV diagnosis. You get a blood pressure of 60 over 40. Is it accurate? Probably not. So what I'm saying is on an infant that's kicking and screaming and moving and you're taking a blood pressure on their calf, just be prepared that the blood pressure reading is not it's still a value, it's still a data, you still need to chart it, but it's not very reliable compared to like an adult. Like if you take my blood pressure, the blood pressure is probably pretty accurate. On children, when we try to assess blood pressure, it's historically not very reliable. Doesn't mean that that's not a reading that we need to document, but it's not very reliable. So what am I saying? We treat our patients, not the monitor, right? So it doesn't matter if it says 180 over 102. It doesn't matter if it says 60 over 40. If the patient has a capillary refill less than 2 seconds and their SpO2, their pulse oximetry is 98%, we know we're in good shape. Their mouth is moist and they have good skin turgor. We're going to talk about this coming up. But what I want to say is just don't get lost in the sauce of these blood pressure readings on children. The caveat to this is on exams. On an exam, if they give you a blood pressure reading, it's the actual reading, okay? But what I'm saying is clinically, when you get into the field, you'll notice it's very difficult to get accurate vital sign assessments in children, okay? So moving forward, the body weight, or I'm sorry, the body temperature. How we assess temperature in infants is rectal temperatures. Okay, so you'll take like a rectal probe of a thermometer and you'll insert it into the rectum through the anus, and it doesn't have to go very far. If you push it too far, you will perforate their rectum. Okay, so be careful with that. But that is how we assess that in infants. Okay. Um, some ambulances, like I'll tell you, the agency that I used to work for, they didn't have this capability. Yeah, I don't think they had this capability. So we would just use a temporal artery scanner. But I'm just letting you know, ideally, on neonates, especially, and really infants, certainly less than 6 months of age, you should be doing rectal thermometer temperatures. And that's the only time we do that. Okay? This is a really horrific story. There was a guy, I won't say what part of the state of Texas he was in, that I had heard of, that did a rectal temperature on a 17-year-old car wreck patient. Of course, he got charged with rape, right, or sexual assault, because that is beyond horrific that someone would do that. So, just as a general rule, typically we only do rectal temperatures on infants. Okay. Now, moving forward, the weight of a child will vary. Obviously, it depends on how long they're cooking in the oven in the womb. And also depends on like the neonate or the maternal health, like how well is mom doing? Does mom have diabetes? A lot of issues like that. But typically, a neonate will weigh between 6 to 8 pounds ish. Okay, and that should double within the first half year, and it should triple within the first year. So weight is generally in size. Weight and size is generally a pretty good indicator of maternal health and neonatal health, right? So underweight babies are typically really unwell. That means they did not get the nourishment or there's some type of birth issue. So, a 3-pound baby is generally not going to be healthy, okay? So just be aware of that. The laws change. They're not going to ask you this on an exam, but typically a viable baby, not my opinion, by the way, a viable baby is it varies, around 20 weeks of gestation and around 500 grams, which is a half a kilogram. So, the whole discussion on babies and viability, we're not talking about that in class, but I'm just letting you know that's what the literature says, okay? Now, at birth, the neonate they'll transition from fetal to independent circulation. So fetal circulation, so this is this thing called the placenta, and it's bound up to the uterine wall, and there's diffusion taking place at this wall. There's not direct anastomosis, so there's not actual connections of these vessels. There's like a diffusion-like process is taking place. And what's happening is they're taking mom's glucose and mom's oxygen and delivering babies carbon dioxide and cellular waste, and they're exchanging through the placenta. And it goes through the umbilical vein, which is oxygenated blood. So let me say this again. From mommy's belly to the baby, it's the umbilical vein. and this is oxygenated blood. And the reason I'm telling you this is, and it's an exception, because you're like, wait, Hunter, I thought veins were deoxygenated. They typically are. The exception to this is the pulmonic vein and the umbilical vein. Okay, so why? So do you think examiners go after that? Yes, they do. So the umbilical vein carries oxygenated blood from the placenta to the baby, and the idea is there is this bypass through the heart because obviously when the baby's in the placenta or in the womb within the uterus, they can't breathe oxygen, right? They can't breathe air in and out. They can't ventilate. So they have to bypass the lungs more or less to allow it to get to the blood to get to the left ventricle and be pumped around the baby's body. So the baby's heart is beating, obviously, but the lungs are not breathing in and out. So this becomes, or they're not breathing in and out oxygen, I should say, gas. So this is a kind of a process that when the baby's born and they take that first screaming breath and start screaming and crying, then this circulation will shift, and it should happen pretty quickly, within minutes, right? Should. And this hole in the heart the foraminal valley, right, should close up, and circulation and it should switch, and air should be coming in and out of the lungs, and that is the switch from fetal circulation to independent circulation. Real quickly, we'll talk about this more, but I want to point something out. So, the baby's umbilical cord looks like this, and there's two arteries and a vein. Remember, the vein is carrying oxygenated blood. It's very big, okay? So the mnemonic is AVA. Someone named the name Ava, A-V-A, right? There's two arteries and one vein. The vein carries oxygenated blood from the mama to the baby, okay? Now, the neonates are what they call obligatory nose breathers, right? So when we get really short of breath as adults, I might huff and puff and blow the house down with my mouth, right? Babies can't do that. So where this becomes important is they get nasal congestion, and a baby can't raise their hand and say, yo, daddy-o, my nose is stopped up. They can't do that. So as parents and caregivers, you have to suction their nose out. Who knew? And again, they're not going to raise their hand and say, Kleenex, please. So you have to use these things called bulb suctions. That's what this is here. You'll push the air out and you'll suck the mucus out of the baby's nose, squirt it down, and then do it again and squirt it out. So very important to look for this in children. If you ever get a baby call, you need to assess their nose and see, is it congested? Because remember that infection I told you about earlier, the viral infection, RSV? RSV very commonly presents with nasal congestion, like severe nasal congestion. So you'd be shocked how many kids come into Cook Children's and I'm like, oh my gosh, this baby, of course they're crying and losing weight and can't breathe and feeling terrible. They can't breathe. They cannot be like, oh, my nose just stopped up, so I'm going to switch to breathing out of my mouth. They can't do that. So where I'm getting at is it's very important to assess this in babies and for us to intervene and suction their nose. And then further, to educate the parents to do this as well. A lot of education was given when I was working at Cook Children's to the parents of like, again, the baby can't raise their hand and say, yo, Kleenex, can't breathe. So with that, the rib cage is less rigid, and the ribs sent more horizontal, right? Like more like this, like with the horizon instead of like kind of at an angle. But that's not as important as the nose thing. The nose thing is very, very important to assess for a baby, okay? Another example, when the baby's sucking on a breast or a nipple or a bottle or whatever, they have to breathe through their nose. So if they're, sucking with their mouth and they can't breathe through their nose, you'll get the complaint, oh, my baby won't latch onto the nipple. They won't take a bottle, right? And that's a pretty big red flag that, oh, you should probably look in their nose and it's maybe congested, okay? Very common complaint. Even healthy babies will get congestion, right? So very common complaint. Now, the infant has a ginormous tongue in correlation to like adult and the size of their mouth. So their tongues are pretty big, but what's more important is they have a narrow airway. So remember the trachea, the little air tube, the rigid air tube that runs in front of us? On babies, it's not as rigid, and it's a lot more narrow in comparison to my size and my trachea size. So it's very narrow. And instead of this being like something like mine, it really doesn't like want to bend. It's like instead of like a straw, it's like a soft rubber tube. So the trachea, instead of being rigid, it's very soft. So the baby's trachea can be a lot more easily like pressed on and occluded. Hyperextension of the neck can even include it. A flexion of the neck can occlude the baby's trachea. So these are all considerations with a baby. Um, and also remember that an infant's lungs are fragile. Cannot stress this enough. It drives me nuts when you see people in like a BLS class and they're like, whoosh, whoosh, just like bagging the crap out of the mannequin, because how you practice is how you play, and this can cause what's called barotrauma, BARO trauma, barotrauma to the lungs, which is like translates to pressure trauma, because you can seriously pop a lung in a baby. Their lungs are very, very small. And all you have to do is squeeze that bag, this bag valve mask right here. All you have to do is squeeze it until you see chest rise and fall. That's it. Not until you can't squeeze anymore into their fragile lungs. It is just until you see chest rise and fall. And this is something we'll be very particular about in lab because it's important. It's very, very, very important that we do this right. I'll tell you now, and I'll lay a foundation for the rest of this class. The most difficult skill an EMT or paramedic can do is using this tool right here. This is incredibly difficult, especially on people with beards and fat people and skinny people and people with messed up faces and infants and people with smushed faces and whatever. People with traumatic faces and blood and missing teeth and dentures. This is very, very, very difficult to be good at. A monkey can do it, but to be good at it, and we want to be the best in our field, this is very difficult. So just be aware that we'll practice a lot on this in class. So the baby's nervous system, okay, as adults, I told you earlier, our nervous system, once it's done, especially the central nervous system. Peripheral nerves are a little different. But the central nervous, once it's done, probably, I think the age is around 11, it's done. Years of age. It's done. It doesn't really do much after that. It's been built. Now, what's different is in neonates, that's not the case. So it's continuing to evolve and it's continuing to grow. Myelination is continuing to happen, which is like the coating on our nerves. Maturation, it's maturing, it's growing in size, it's growing in numbers. So the nervous system does grow in children. But we assess the nervous system in children in a few different ways. We use these things called primitive reflexes, okay? And these are different from reflexes of like when you touch the stove and you pull your hand back. It's a little different because these are from an underdeveloped frontal lobe. So infants don't have a developed frontal lobe yet, right? Like it's there, but it's not very smart yet. And so we can see some reflexes, right? Like, for example, the Morrow reflex, right? So basically, if you were to startle a baby, it could be a loud noise. You could kind of like lean them back a little bit quick. They will go like this, right? Like so they'll like kind of like try to hold on, right? That's the Morrow reflex. Rooting reflex, I did this to my nephew the other day. It's kind of funny. You'll go up and you'll stroke their teeth, and they will turn to latch onto a nipple, right? And it's like, oh wow, that's a pretty good reflex for a breastfed baby to have, right? The sucking reflex, so again, the rooting reflex is when they turn, but the sucking reflex is if you touch the top of their mouth, which I don't recommend you do, they should suck, okay? Because they think, oh, there's a nipple in my mouth, right? The palmar grasp, this is when they'll curl the fingers if the palm is stroked, right? So they'll latch on. Plantar reflex, right? So I'm not going to show you my feet, but this is called the Babinski sign, right? So if this is someone's foot, right, what you could do is you could take your pen and you can run it up their foot, like down from their heel up to their big toe. And in adults, we'll go in like this, okay? In infants, they spread out and fan backwards. And in an infant, this response is normal. But on an adult, when we go like this and they fan out like that instead of curling in like they're supposed to, again, this is their foot. I'm just using my hand as an example. That's a problem. We think, oh, there's probably an upper motor neuron lesion, right? There's something wrong. But these are all reflexes that we use. There's the Gallant reflex. It's where you stroke their spine and they'll kind of turn. There's all these different reflexes out there. I would spend a whole lot of time memorizing these. Babinski reflex is probably the most commonly used one in EMS and tested on, which is the plantar reflex. So just be aware of that, okay? Now, babies, they have their skull's not fused yet. And by design, when they're pushed through the vaginal canal through the hips, right? Um, if it's just a solid bowling ball of head, then then the baby probably would not push through the birth canal, right? They'd have to have a cesarean section. But by design, God said, well, let's just make it. Let's not fuse these together yet. So the skull is not fused together yet, and it's four different plates. There's more than four, but this top view is four. And basically, so when they go through the birth canal, the skull will kind of squeeze like a cone and go through. So you ever seen those vaginally born babies that were like in the birth canal for a long period of time? They look like cone heads. Um, that's why, because their skull's not formed. Now, there's this thing called the fontanelles, and that's this area right here. And on a baby, you would feel it right about here. You don't push very hard, but you could feel it. And it's an area where the skull is not fused at all, and directly underneath that is the skin, and then there's the meninges. And we use this clinically because if someone has like a really deep depression within the skull, right there at the anterior fontanelles, then we would think, oh, they're dehydrated. But if it's bulging, we would think that's increased intracranial pressure. So intracranial within the head pressure, right? So this could be from shaken baby syndrome is where you'll see this. You will also see this in meningitis, right? So when these meninges, the layer of the brain, remember the order from the brain, from the brain up to the skull is the pneumatic pad, pia mater, arachnoid mater, dura mater, right? But when they become infected by bacterial, fungal, or viral infections, this fontanelle will bulge, so it'll be sticking out. And that's a clinical sign that we look for. Yeah. So the growth plates aid in lengthening of bones. So after puberty, this stops once we reach your maturity height. And then the bones will obviously increase in thickness. Now I will say this is gnarly, but babies' bones are I wouldn't say very soft. They're soft, right? They're almost pliable, especially compared to an adult's bone. Have you ever pulled a tree, a limb off a tree, like a really green tree, and tried to snap it? They're pliable compared to like an older dead tree. They'll just snap, So they're more, these are like green branches, and we actually have something called a green stick fracture that happens in children, which we'll talk about in orthopedic trauma. But where I'm getting at is babies' bones are soft, and they're cartilaginous, and they're softer, and they're not fully ossified yet by design. And their joints aren't very rigid yet, and their tendons are nice and pliable, and ligaments. And where I'm getting at with this is, like, for example, if you do CPR to an 88-year-old female, it sounds like a bag of Doritos when you start doing compressions on them, right? You're breaking all their ribs and their sternum. But I've done compressions on infants and neonates, and you typically won't break their ribs, or you'll just break a couple of them because they're that soft. So I'm trying to give you a relation of they're that soft that even through several rounds of CPR, you probably won't break a lot of their ribs, or they'll break as you continue more rounds of CPR. Remember, broken bones and chest compressions does not mean you're doing it right or wrong. Now, the renal system, so infants, again, can't be like, yo, water please. They can't do that. So they're at risk, especially in cases of neglect, to becoming very quickly dehydrated. They're also at risk of dehydration in cases of vomiting and diarrhea. And failure to feed, right? If they're not latching onto a nipple, right, because their nose is congested or they're sick or whatever the reason is, whatever reason, they can become very quickly malnourished, and dehydration is the first thing you'll see, and that's intuitive, right? We would die from dehydration prior to malnutrition, even as adults. But they become dehydrated very quickly. The kidneys cannot produce concentrated urine as well, right? So the kidneys aren't smart enough to say like, oh, we'll hold on to more water and just concentrate our urine. That way, they're not smart enough to do that yet. The kidneys aren't mature enough to do that yet. And the infant's urine consists mainly of water. Again, their urine is not very concentrated like ours would be. So with that, I'm showing you an example down here. This is called skin turgor. So spelled like this, skin turgor. And basically, you could do this on adults, right? So you could take my hand and tint up my skin on the back of my hand and let go. And since I'm hydrated, the skin goes right back to where it's supposed to be. But on an infant or someone who's dehydrated or even an older person, That tends to not be the case when they're dehydrated. And what happens is the tin will stay tinted. So it stays in place even after you let go. It doesn't quickly go down. And they're showing that to you here on this infant. You can assess this on their abdomen. On an adult, we tend to assess it on the back of the hand. You can also assess it up on their scalp. You could take a piece of their scalp and pull it, pinch it together, respectfully pinch it together and then let go. If it stays tinted up, that's a pretty good indication of dehydration. Another good assessment tool for dehydration is looking at what's called the oral mucosa. So if you look in a baby's mouth and it's bone dry, that's a problem. Or even an adult's mouth and it's bone dry, that's a problem. Probably means they're dehydrated. So hydrated people tend to have moist mucosa, moist mouths. So that's a good thing that we'll look at if we're trying to decide is someone dehydrated or not. Well, it's a simple test. Have them open up their mouth, and stick out their tongue. If there's a bunch of spit in their mouth, probably not dehydrated. Okay. Now the immune system, infants are really, they don't have all those memory B and T cells yet. So they're at risk of infection, and that's because their immune system is just not developed yet. Now, with that, they do receive antibodies through breastfeeding. So this is the benefit of breastfeeding a child if the mother's capable and or willing, because they receive what's called IgA antibodies, which has a lot of, not my opinion, but a lot of scientific medical benefits to breastfeeding a baby for immunology purposes, especially. Um, so this is why it's important to vaccinate children, and to breastfeed if possible, and really to avoid unnecessary exposures, right? Don't have random strangers in Walmart kissing and touching your baby. Um, you know, this is how I mean, this is how babies get chickenpox and herpes and stuff way too young, and get viruses and RSV and all these issues. So that's a whole nother discussion, and gets off topic. But anyways, so the psychosocial changes, right? So it begins at birth, right? Um, Infants are constantly interacting with their environment, right? And they're reacting to their environment, right? Just as mammals do. And just be aware that a crying baby is a healthy baby, right? So in EMS, a cry is a wonderful sound to hear. Because if you have a baby that's throwing a temper tantrum like this one, although adorable, that's a healthy baby. Babies that can sit there and scream their lungs out, it's just like music to your ears in an ambulance, because you're like, okay, they're moving air, their heart's beating, they got enough energy to cry, we're good, we're gonna be okay. It's when babies get really, really quiet and they can't cry where it's very ominous. So a crying baby is a healthy baby generally, right? So just be aware of that. I'm not saying we intentionally piss off babies and have them cry, but which we do occasionally. But what I'm saying is a screaming baby has a good set of lungs on them, and they're moving air, and their heart's beating, and it's a good thing in emergency medicine. Now, so babies eventually, this doesn't happen at birth, but eventually they'll develop attachment, right? Or anxious avoidant attachment, right? So basically, when they're detached from their mother or father, caregiver, whatever, they could become anxious and start crying or fussing or whining. This doesn't happen just straight out of the womb. Typically, this is as they start to age, like separation anxiety, for example. It's as they age. We're talking 6, 7, 8, 9, 10 months of an infant, right? Older infants can have what's called separation anxiety. So be careful saying that the 1-week-old baby has separation anxiety. It's the wrong answer. It's not how that works. Now, infants desire plan, organized routine. So this really is important. Like my brother, they take the baby on a walk during the day so it gets sun exposure, so it'll try to sleep all night. They feed him on a schedule, so he poops on a schedule, he gets bathed on a schedule. And this is really good if you don't want to be up all night with a crying infant, is to try to implement that schedule. And of course, something that I should encourage you to do is use the parents as historians, right? Is this normal? How many wet diapers has he had today? How many times has he pooped? When's the last time he pooped? How long has he had fever? How many hours has he slept today? When's the last time he was breastfed? All these historical facts we can gather from the parents become really relevant and helpful in our assessment and determining how sick this baby is or isn't, and we use that a lot. Okay, so let me tell you this. So the infants will develop trust or mistrust in caregivers, right? That's a whole nother discussion. It kind of opens up the door to like abuse. But um, when you're treating an infant, or really when you're treating a child at all, even preschool, adolescent, You're also treating the parents. I can't stress that enough. Like a big job on my part of my a big part of my job at Cook Children's was treating the parents, right? Explaining to them what's going on, educating them, talking them through the process, letting them know what's coming next. And of course, we do that to children too, young and old. I'm explaining an IV to a 2-year-old in 2-year-old terms, right? And I'm also explaining the value of this to the parents and why we're doing it and what we're looking for, and the lab test that we're doing. But what I'm saying is, you can't assume anything on this. You can't assume the parents know what's going on. You can't assume the kid knows what's going on. It is your duty. It is your obligation to explain what's going on to the parents and the infant. So toddlers, that's it for infants and neonates. So toddler age, this is 1 to 3 years old of age. Um, Notice I keep saying like years, so I have to be careful saying, oh, this is 1 to 3s, right? It's 1 to 3 years. So because what does that mean? Does it mean 1 to 3 months? So try to use the unit of measurement, right? So it's 1 to 3 years. And they're giving you the normal pulse and stuff like that, right? So a pulse of 80 to 140, respiration rate of 22 to 37, and a blood pressure, a systolic blood pressure, so the top number of 86 to 106. That's a little bit, so I mean, look, the pulse rate in comparison to adult, me and you, right? Their pulse rate, their pulse rate, geez, is higher. The respiratory rate is higher, but their systolic blood pressure is lower, but their temperature is generally higher. So that's how this might be examined, right? They're not going to ask you, your patient has a blood pressure of 85 over 50. They're not interested in that, but they want you to realize that there's these nuances in infants and neonates and adolescents and their vital signs. So let me point this out. Look at the respiratory rate here. So infants, 1 to 3, or I'm sorry, toddlers ages 1 to 3 years of age, they breathe once every 3 to 2 seconds, right? So they're breathing once every 2 seconds. That's pretty fast, right? So a lot of times when I'm assessing these patients, I'll just look at them like a neonate. Sometimes I'll breathe 40, 50, 60 times a minute. And I was like, okay, they're breathing 1 time a second, right? So it's 60, boom, put it in the computer. And like a toddler like this age, I look at them, they're breathing once every 2 seconds, boom, the answer is 30. So sometimes I'll use that to my advantage. Like, they're breathing once every 2 seconds. I don't have to sit there and like count them, like how we normally count respirations. So just be aware of that. It's a tool we can use. Now, preschool age children, this is age 3 to 6. This is when children typically start to enroll in preschool. I'd say probably closer to age 4, but anyways, the pulse is 65 to 120. So again, this is higher than adults. It's higher than adults. The respiratory rate is still higher than adults, and the systolic blood pressure is still lower than adults. So notice the trend here. The heart rate is faster, but the blood pressure is lower. Why is that? I'll explain this because it may make sense, and help you later on. Toddlers and infants and neonates and preschoolers and really even school-age children, they can't squeeze down on their vessels very well. So they can't be like, okay, I want to squeeze down on my vessels to raise my blood pressure, which would increase systemic vascular resistance, which would increase cardiac output. What they can do is they can increase their heart rate really easily. So what I'm saying is it's easier for an infant to increase cardiac output, to increase their heart rate, than it is to increase their stroke volume or their systemic vascular resistance. So what I'm getting at is what we see clinically on a normal day for normal physiology is infants have really fast heart rates, and neonates and toddlers and school-age children, they have faster heart rates and generally lower blood pressures. Why is that? They have lower blood pressures because they cannot squeeze down on vessels as well as you and I can. And that maintains our cardiac output. And so the way they compensate is through an increased heart rate. That's the idea behind that, and I hope it makes sense. So, passive immunity is lost. Passive immunity is lost. So basically, children should be pretty much almost fully vaccinated by this age. Let's see, the neuromuscular, the baby grows, you start potty training them, teething occurs. I mean, it's pretty intuitive. Don't have a lot to add on that. Now, the toddlers and preschoolers are learning how to speak and express themselves, so they should start mastering basic language. They're not going to ask you developmental milestones, like when should they be able to ride a tricycle, and when should they be able to stack 3 cubes, and carry complete sentences. They're not going to ask you that on the exam. This is just general knowledge type stuff. Um, they learn to recognize sexual differences. So boys might start hanging out with boys, and girls might start hanging out with girls as friends and playmates. They should try to start interacting with children during games. That's sometimes a sign of autism or Down syndrome. Not Down syndrome, more so autism is the child that doesn't engage with other children at the playground. Stuff like that. So just be aware. That's things we look for. Now, school age child. This is age 6 to 12. Notice their vital signs are getting a little bit more adult-like, but they're still not quite there. So uh, their pulse rate 58 to 118, respiratory rate 18 to 25, and the systolic blood pressure is getting closer to the adult systolic blood pressure around 110 to 120 ish. Is probably where most adults sit. Okay. Now, a school age child, which is age 6 to 12, they will gain about 4 pounds and grow about 2.5 inches each year. Right. So this is pre-puberty. This is normal. So they want to have typically won't have puberty yet. And the brain function develops further in both hemispheres. It's really throughout the entire brain. Permanent teeth will start to come in. It's intuitive, right? So children learn reasoning. So what makes the human species as mammals so unique is they think that we're one of the only mammals that have reasoning, right? They can determine right from wrong and multi-step problems and things like that. And that's what we're talking about with reasoning. I don't have a lot to add on that, but so a school age child begins to develop like self concept and self esteem. Like, this is who I am. This is who I want to be. This is my worth. This is my value. This is my comfort. Right? Like, so that's intuitive, right? We see that in school age children. In the home life and their school life in their social life play a really big role in all of these. Like, it can't be understated. Like, psychosocial changes are big in all the school groups or in all the age groups, but um, home life plays a really, really big role in how a child develops. So, adolescent. Notice this is age 12 to 18. It is not teenagers. It is age 12 to 18. Um, so, yes, an 18-year-old is an adolescent, even though they're legally in the eyes of the law an adult. So, the vital signs pretty much become adult-like. Okay. The puberty will occur. What's the first sign of puberty in females? It's breast bud development. Not that we won't assess that as EMTs, but be aware that a female can be in the process of early puberty without her first period. Okay, so menstruation actually happens 6 months to a year after the onset of puberty in females. So I'm just letting you know that while a lot of people think like a female's period is the onset of puberty, it's really not. It's several months before that. So secondary what we call secondary sexual characteristics begin to develop. In females, this will be pubic hair and breast development, and then in males, this will be underarm hair, pubic hair. So typically, what you'll do is you'll just look underneath like a male's arms, and if there's hair there, then you assume like, okay, then they're pubescent is the word pubescent. Um, so just be aware, obviously in puberty, rapid growth happens, secondary sex characteristics develop, the testicles will drop and develop in men, menstruation will occur in females, lots of big hormonal changes, exciting time to be alive. So the adolescence, this is really kind of struggle for independence and, trying to really gain control of their life. Privacy becomes an issue. So, maybe they used to walk around the house naked as a 5-year-old or 6-year-old or even sometimes older than that. But they want more privacy. They want to be left alone. They don't want people to always, may want the door closed, stuff like that. So be aware of that. Even men or something like that. Like if you do a 12 lead on them, they may feel private, right? They may want to be covered, especially teenage females. You want to respect their modesty and their privacy. But privacy is a lot more than modesty. You know what I'm saying? Just privacy, right? Self-consciousness increase. So they may feel a little insecure on their appearance or their ability or whatever. So they're self-conscious. So affirmation becomes really important in affirming them in their identity. So they may struggle to create their own identity. So again, affirmation of identity becomes important as parents or friends or teachers or educators or whatever. And peer pressure becomes a major factor. And, I'm sure we've all been suckers of peer pressure. And now as adults, we might look back and say, wow, I can't believe I did that. And if you look at it, it's because of peer pressure. So don't underestimate the power of peer pressure, whether it's engaging in risky behavior, sexual behavior, drugs, dangerous behavior, uh, high risk behavior. Peer pressure has a lot of influence on the adolescents, and it's not abnormal in that fact because it's so common. It's almost to be expected. But peer pressure, because peer pressure is common, doesn't make it any less dangerous, right? It's still dangerous. Risky sexual behavior and drugs, and just straight up risk taking behavior like stunts and stuff like that. It's still dangerous. Okay, even though it's common and normal, right? It's still dangerous. So I hate the fact they use antisocial behavior peaks in eighth to ninth grade. Um, what they're getting at, and I went and read the book on this. What they're getting at is like uh, I believe they weren't very clear. I believe what they're getting at is like avoidant, right? Because typically the word antisocial does not mean what you think. Antisocial, okay, in an adult, right? If someone has antisocial personality disorder, it means that they don't follow societal norms in relation to the law. So if someone smokes a lot of weed and, they're, I don't know, getting arrested for DUI and engaging in fights and whatever they're breaking the law, destroying property, we can diagnose them if they had this behavior as children, which would be conversion disorder. They can have or conduct disorder. I'm sorry. They can. What I'm getting at is an adult that doesn't follow the law and it has a personality disorder that's diagnosed. That's called antisocial personality disorder. And I don't think that's what they're trying to say because eighth and ninth graders don't typically break the law at high frequencies. I think what they're getting at is the fact that they're like less social. I don't really know what the book's getting at with that, but if I'm writing your exams, it's not going to be on your exam. So, and I doubt the National Registry would care about that. But anyways, there's greater interest in sexual relationships in adolescence. This is something that you have to be mindful of. I've seen personally an 11-year-old get pregnant before when I was working in a pediatric hospital. So you have to be aware that it can happen and that very young children can get pregnant and you could technically get pregnant before your first period if the timing was right on that. And just be aware of that. Okay, very long discussion. Where I'm getting at is we don't see a lot of this in EMS, but you can't necessarily rule out sexual assault or sexual abuse. But where I'm getting at more specifically is like STDs, STIs can still happen in 12 and 13 and 14-year-olds, right? They could even happen in like 5-year-olds, which is disgusting and terrible. But just be aware that can happen. We just have to maintain a level of professionalism and work through that. One thing I'll tell you though, of all the age groups where it becomes really important to have a chaperone, ideally of the same sex as the patient, it's probably in the adolescent age. You need to be really careful assessing these patients alone. Um, it's just the culture we live in. Okay, so if you have a female partner and they can do the 12 lead, or if they can do the lung sounds or abdominal exam or whatever, that's probably ideal if you're a male. Okay, so if you're both males or both females, you should both ideally be present during that exam. That's just a general rule of thumb. The rule carries on into adulthood, right? To where if you can have a chaperone, you always should. But just be aware of that. Anyways, their code of personal ethics should develop. So early adulthood, this is age 19 to 40. This is me. Um, uh, adult vital signs, who knew? So um, from age 19 to 25, the body should be functioning at optimal level. I'm 28, almost 29 in a couple of weeks, years old. And I would agree with this. Like, I'm feeling older by the day, and it's quite scary and frightening, actually a little bit sad. But anyways, ideal body, 19 to 25. That's when you're firing on all cylinders. Everything's running smooth, and it just gets worse after that. So wear and tear on the bones, and the muscles will begin, and then basically the body starts, getting worn out. That's what happens. So, and in an early adult, which is age 19 to 40, your life really centers on school, work, family, stress, right? And you're striving to create a comfortable place to live and settle down in, right? You may choose to have marriage or childbirth. That's rather common at this age. But the idea is, we tend, especially as Westerners, right, Americans, we tend to focus on school, work, and then family. So middle adults, right, age 41 to 60, the vital signs remain the same. They're still adults. The body is still functioning at a high level, but I want to point out it's not as optimal when you were age 19 to 25. So you're vulnerable to vision and hearing loss. That's called presbyopia and presbycusis, right? So that literally means old eyes, old ears. And that's not surprising, right? Where your eyes will get worse. The cardiovascular system becomes worse. We're going to talk about the specifics of that. Your cancer incidence increases as we age. This is a good fact to know. There's several reasons for this. I would say the biggest one is as we age, mutations start to occur, and bad genes have the chance to express themselves more frequently and get stopped less frequently. So you can start showing signs of diabetes and hypertension. Menopause, if you don't know, menopause is when you stop having a period or menstruation. And this typically will occur in the late 40s to early 50s. There's a specific criteria for like the diagnosis on this, but basically the periods will decrease in frequency until they just stop. And at the stop would be menopause, okay? The stop of menstruation. So exercise and a healthy diet can diminish the effects of aging. Can't agree with that more. So there's focused on achieving their life goals and maybe readjust their lifestyle as the children leave their home. They generally have physical, emotional, and spiritual reserves to handle life's issues. Maybe caring for children leaving for college and aging parents as well. This is very intuitive. I don't have a lot to add on that. So this could show up. This is epidemiology, right? An epi question. Excuse me. The leading cause of death. Unintentional injury is the leading cause of death for all of these people. Toddlers and preschoolers, school-age children, adolescents, early adults, and adults 41 to 44. So that is a lot of age groups, right? So basically from birth, toddlers, right? So from age 1 to age 44, you're at risk of your highest chance of dying is from unintentional injury. Car wrecks, falls, motorcycle accidents, gunshot wounds, whatever. Unintentional injury. So what does that mean? We see a lot of trauma in these patients where it's severe enough to kill them. And you would ask yourself, well, why do we see trauma in these patients? It's because they tend to engage in more risk-taking behaviors, right? Skiing down the mountain, skydiving, shooting guns or whatever, war, high speed, motorcycles, whatever. They engage in risky behavior. So we tend to see this is the most common cause of death in that age group. It's unintentional injury. So it's trauma. Now, cancer is the most common leading cause of death at ages 45 to 60. Okay. I'm willing to bet you could name off several people in your head that have cancer. Think of when they were diagnosed. I bet their age falls within that group, probably 8 times out of 10, which is really sad, but it's just the truth. Now, heart disease and cancer are the leading cause of death of age 65 and older. So that's our geriatrics, okay? Heart disease is a pretty big cause of death in the United States. In fact, it may be the leading cause of death. I'm having a blank on that, but I'm pretty sure heart disease is the overall leading cause of death in the United States. Or cerebral vascular disease for sure. Or cardiovascular disease, sorry. So older adults, this is age 61 and older. Life expectancy is changing, so it's increasing as medicine's getting better and better. People are living longer and longer. But right now in Western, the United States, the approximate life expectancy per them is around 78. I thought it was a little higher than that, but that's fine. But 78 years of age is typically how long Americans will live. It depends on several factors of how long you're going to live. Basically, where you live, how healthy you were, how rough was your life, how well did you take care of your health, were you obese, did you have diabetes, did you have uncontrolled high blood pressure, right? All those are going to play a really important role. Occupation are going to play an important role into how long you're going to live, okay? Yeah, your vital signs will depend on the overall health, medical condition, and medications taken. So with medications taken, there's a word I'll plant now, something called polypharmacy. And the word poly literally means many, so many pharmacy. So they take a lot of medications, okay? So a lot of medications can interact, and sometimes we intentionally lower blood pressure. Sometimes we give medication to raise it. It's really weird, but they often take multiple medications, and these multiple medications is called polypharmacy. You'll see that on exams. Polypharmacy. Poly means many, and pharmacy, obviously. So generally, as we age, what I want you to know, I'm going to flip through some slides. Everything gets worse. Like literally everything. Your vision, your hair, your skin, your eyes, your teeth, your heart, your vessels, your gut, your genitalia. I mean, literally everything gets worse. It's really sad. But generally on a test, if you can sit there and think, oh yeah, this is probably one of the worst sounding things of the answers, you're probably going to get the answer right. Literally everything gets worse. So don't pick something to where it's like, oh, an 88-year-old lady has better vision. No, wrong. No. It's going to be the worst, everything either generally slows down and or gets worse. Okay? So the cardiovascular system, it will decline, get worse, with age, largely due to atherosclerosis. What does this look like? So if this is a vessel, what happens is eventually you'll have streaks of plaque that will build up in there, and that plaque will eventually decrease the lumen of blood that can run through this vessel, and so that causes a decreased blood flow. Okay, and consequently, it also increases the blood pressure sometimes, but just be aware. So heart rate and cardiac output decrease. Okay, so you don't have to pump as much blood throughout the body as we age. You have less muscle, you have less metabolic demand. Again, everything's slowing down, so there's less need for blood to be circulating as fast and as hard. But the consequences of this is the vascular system, because of aging, atherosclerosis, and this other thing called arteriolosclerosis, the vascular system becomes stiff. So instead of these nice rubber hoses for our arteries and veins, they become like bendy straws, right? They become more stiff. So they have less compliance. So they're not as friendly to your heart. And so the ability to produce replacement blood cells declines, so your bone marrow starts giving out, and your blood volume actually will decrease as you age, okay? A little bit. It's not like drastic, but it does. So the respiratory system, the size of the airway increases as smooth muscle weakens, okay? The natural elasticity of the lung decreases, and there's loss of mechanisms that protect the upper airway. So a general rule is as we age, especially as Westerners, especially as Americans, the general rule is you can tell yourself, and we'll cover COPD in great detail, that old Americans have COPD. Even if we didn't smoke, you were still exposed to environmental toxins, car exhausts, secondhand smoke, fireplaces, whatever. You're still, so basically the rule is if you look at these things, this is describing COPD. An increase in airway, the size of the airway increases as smooth muscle weakens and surface area of alveoli decreases. Emphysema, that's under COPD. Natural elasticity of the lungs decreases. Emphysema, that's COPD, right? Changes are often gradual. Boom, so is COPD. Notice the word C, chronic, right? Loss of mechanisms to protect upper airway. Boom, COPD, that's more of a bronchitis thing. But what I'm saying is, if you can say, oh, old people have COPD, even if they didn't smoke, they still have a form of COPD generally. You'll get these questions right. Okay, I'll move over here. I took this out of a medical school book. It's a little bit advanced, but it might help you. It's like a very brief summary. It's not brief though. It's very condensed summary. Now, again, the muscles weakening can lead to airway collapse. So basically, these get worn out. Same thing. The same thing happens in COPD. That these will get worn out and they'll collapse on themselves, and that creates obstruction. Right? This is obstructive pulmonary disease. The vital capacity decreases. Right? So this is how much air that you can consciously take a breath in, and then the residual volume will increase. So this is how much air is left in the lungs. So again, COPD is a hyperinflated chest. The lungs become really large because of you have obstruction where you can't get air out. So what I'm saying is this is COPD. Old people get COPD. The endocrine system, so it does slow down. This is intuitive. The hormones slow down, right? People tend to slow down physically people tend to slow down physical activity but not decrease food intake. So insulin, so the beta cells of the pancreas will eventually kind of crap out on you, and so it's from exhaustion. The literal word is the exhaustion or burnout of the beta cells of the pancreas. It's in the tail of the pancreas. So this ends up eventually with type 2 diabetes mellitus, right? So type 2 diabetes happens in old people because the beta cells of the pancreas, along with several other reasons, eventually can wear out and they'll stop producing insulin. Um, the reproductive system changes to some extent. One thing I'll have you know is that most men are fertile, uh, as in still produce sperm, up into geriatrics, right? So now, obviously, after menopause, female are no longer able to conceive and have children of their own. But their men can still produce sperm, and so they're still technically considered fertile. And I'll have you know an interesting fact. Just because someone ages does not make them any less interested in sex. So be aware of that. You know, 85-year-old man can still be interested in having sex with his wife. Okay, and that's not pathological or anything. Now, we covered this. So the filtration of the kidneys will decline. The kidney mass themselves will decrease. So the actual kidneys themselves shrink a little bit as we age. The ability to clear waste from the body and conserve fluid decreases. So again, the kidneys become less optimal, less efficient, less good at their job. Again, as I told you, everything gets worse, right? So change in GI function may inhibit nutritional intake and utilization. Excuse me. So we tend to not absorb food as well. The gut can sometimes slow down. Constipation becomes a really big issue in older people. So you get what I call the FOS complaint, right? Full of poop, where they'll have left lower quadrant pain, right? And that's a pretty good idea. Like, okay, well, they might have constipation among many other pathologies, but constipation is a very common complaint that we get in older people because the gut slows down. Um, and then they also aren't aware that they need to poop, so it comes backed up. Anyways, um, so taste bud sensitivity decreases. This actually happens in adulthood too, and starts to gradually decrease. The teeth become weaker. This isn't a surprise. So dentition becomes an issue. So you'll see dentures are pretty common in older people. It's because their teeth have become weakened and brittle, and they've eventually been pulled and replaced with dentures, which are false teeth. Saliva decretion will decrease. Again, this contributes to the weak teeth. Saliva keeps teeth, uh, prevents bacteria growth on teeth. It helps prevent bacteria growth on teeth. So the gastric motility slows. I've told you this. This is to be expected. And this is very, very, very common. You see this complaint a lot. So they'll complain of bloating and abdominal bloating and gas and constipation, you know. So the gastric acid secretion diminishes. So again, they're not able to digest food as optimally. So uptake and nutritional factors can become a problem. So the anal sphincter changes with reduced elasticity. So remember, what's a sphincter, right? It's a muscle that is in a round formation to where when it is stimulated, it'll open, and when not, it'll close. So we have them in our esophagus, our stomach, our intestines, and of course, the anal sphincter, the anus, okay? Now, the brain decreases in weight and size, and we're going to talk about this on this next slide. Whoops. So the motor and sensory neural networks become slower and less responsive. So, for example, if I were to push you, 28-year-old student, onto the floor, you're probably going to make a couple trips and try to catch yourself, okay? And you probably will successfully catch yourself or maybe not even hit the floor. Or if you're walking and you trip on a rug, you're probably not going to end up hitting the floor. But what happens is in older people, their motor and sensory network is not as fast as processing data to where when they trip on a rug or they get pushed or they miss a step or whatever, they may not be able to catch themselves as quick. So this leads to injury, a really common injury, right? Is tripping on rugs or tripping on pets or something like that. So this is worth knowing. Like, this is why old people fall. It's not just because they're old. It's because their motor sensory neural networks are diminished, right? They're not as responsive, okay? So you do end up with less brain cells as we age. You could have loss of neurons, but generally something to be aware of that older people, you cannot assume, it's a very dangerous assumption, so don't do this. You don't want to assume that they have less knowledge or skill, okay? Always assume that they have optimal or prime intelligence, okay? It's a very bad thing to do is to assume, even demented patients, that they're not intelligent. You can't do that. They still have intelligence. They may just lack some immediate memory or some memory issues. So what I'm telling you is always assume that every patient has optimal intelligence, even special needs, right? Mentally handicapped, mentally retarded, intellectually disabled people, right? You have to assume, um, don't assume that they're not smart or intelligent. Okay, we don't do that. Now, don't assume that they can't hear you or understand what you're saying either, right? So the sleep patterns change. So oddly, as we age, we need less sleep. Um, and odd, again, oddly, you need less REM sleep, which is the one where we produce dreams, the most amount of dreams. And so REM becomes less frequent and you need less of it, and you also get less of it. So sleep need changes. So it's the sleep pattern change that you'll notice in older people. Now, this is a very fun slide. I actually do like this. I'm not being funny. Um, so as the brain shrinks, like it literally shrinks, the skull itself doesn't change in size. So we have these things called bridging veins right here that connect the dura mater, right, which is part of the meninges. Remember, from the brain to the skull, it goes pia mater, arachnoid mater, dura, and from the skull down, it's a dap, right? Dura, arachnoid, pia. Well, we have these bridging veins that feed between the layers of meninges. And see, so these are veins, these are low pressure. And what happens is, as we age, these bridging veins used to be real tight when our brain's real big, like mine right now. But as I age and my brain shrinks, it starts pulling on these bridging veins. And as it pulls on these bridging veins, um, with certain traumas, it can be snapped to where this vein can snap from this smaller brain size. And when it snaps, it's going to leak blood. And when it leaks blood on top of the dura, or below the dura, I'm sorry, below the dura, which makes it a subdura, below the dura, hematoma. So it's called a subdural hematoma. And so we see this. And the classical vignette of this is 82-year-old female with Alzheimer's disease, fell 4 days ago and hit her head in the shower, reported no deficits, and today she presents with left-sided hemiparesis and slurred speech, right? And you're like, that's weird. Why did she have a stroke 4 days later? Well, the stroke initially occurred at the time of injury, but it took a while for the blood to build up to a pathological level to where you could see the physical symptoms. So this is why it's important when old people fall that generally they'll still scan their head, not always, but we'll want to do a CT of their head because you got to worry about these subdural bleeds. And sometimes even they'll come in here and do a craniotomy and they'll drain the blood out of there in the operating room. But I'm just letting you know this is a pattern of bleeding that we see. Now, peripheral nerve sensation is diminished and it's misinterpreted. So they may interpret hot as cold or as pain as, just heat, or, this thing called neuropathy, which is where they just have pain for no reason. Very common in diabetes and really just in aging in general. So just be aware the peripheral nerves change. Again, everything gets worse. Okay. Now, over here, most older adults can see and hear well. Be aware that presbycusis and presbyopia do occur, right? Like they do get worse, but don't assume that they can't hear at all. Okay. And what drives me nuts is you'll see people just shouting at old people. And it's like, you can try normal. And if they tell you to speak up, speak up. But a lot of times with hearing aids, there's no need to shout. Don't cover your mouth when you talk, right? They read lips, right? That's intuitive. And then oddly enough, a lower tone of voice tends to work better than a higher tone of voice. And what you see is when people raise their voice, raise the level of their volume, they tend to raise their pitch. So try to keep your pitch low. Even if you're female, a lower pitch tends to travel better for older people with presbycusis. Okay. So pupillary reaction and ocular movement may become more restricted. So the whole pen light test, it becomes a little less reliable, especially on people with like some type of ocular injury, like glaucoma or can't think. There's a lot. Glaucoma would be a good example. Even just ocular trauma or whatever. Oh God, I can't think of the word. It starts with an M. Anyways, there's macular degeneration. Macular degeneration. So what I'm getting at is that as people age, their eyes become a little less responsive, and so if you were to look at my pupils, they react really quick. But if you look at the same pupils of a 92-year-old female, you might be like, they react, they're just a little bit slow. Well, that's normal for her. Okay, and again, this is why we check pupils and listen to lung sounds and do assessments on every patient. So the next time we run a 92-year-old lady and they really are slow, you'll know, oh, that's really slow. So hearing times is four times more common than vision loss. So again, hearing loss is really common. Okay. There's increased number of older adults in the United States led to more assisted living facilities. We do see a lot of this. EMS, we run a lot of calls there. In fact, if you work in Weatherford, you will go to at least one of these at least once a day. And I'm not hating on it, right? These are the people that pay our bills, but we do run a lot to assisted living and nursing homes. Okay, surprise, right? There's a concentration of older people that are medically fragile. You go run them a lot, right? They need our help, so we go help them. Um, environment problematic during pandemics. Oh yeah, okay. So they're saying assisted living's the environment was problematic during the pandemic. Okay. Um, finances may limit access to healthcare or medication. I see this a lot in medical school. You see this a lot on the ambulance too. Um, on the ambulance, we have the policy you call, we haul, right? But um, what I see now is these people that can't afford the medications that they need, or the treatment or care or procedures that they need, and we on an ambulance get called when their sugar is 400, right? Because they couldn't afford their insulin this month, or they're in a hypertensive crisis because they couldn't afford their medications, or they're in a psychotic break because they couldn't afford their psych meds. And it's really sad that this happens in the United States, but it just is. It's not my preference, but it is what it is, and hopefully one day we can make the system work better for everyone. But be aware that more old people than you think are teetering on financial, or they're financially unstable, I should say, more financially unstable than you think. And uh, sometimes they can't give up food or electricity in Texas. And the more logical thing to give up sometimes is their medication. So, a good question to ask on elderly people is, are you taking all your medications as prescribed? When's the last time you took them? Right? So, just because you have their medication list, you can't assume that they're taking them, or that they're taking all of them, because finances, it just becomes a huge issue as people age. They typically have, well, I mean, granted, everyone does, but they have limited financial resources, right? They're on a fixed income, Social Security and or retirement, or both, or nothing at all. So just be aware. Um, in 5 years preceding death, mental function is presumed to decline. Older adults face the issue of mortality. Uh, That's fine. With good resources and support, older results in their 80s and beyond can enjoy life and feel productive. Yeah, my grandpa's 86. He goes to dances like 2 or 3 times a week, and lives his best life. But it kind of depends with resources and support and just general health. He takes really good care of his health. He takes it really seriously, and he exercises and goes to dances and stuff like that. So, there's variance in this. So that's it for this chapter. I appreciate y'all's attention. Like I said, this isn't like I mean, I wouldn't say that. It is high yield, but it's not like the craziest high yield chapter. But it's kind of foundational stuff that's good to know. And like I said, you probably find this chapter pretty intuitive because you know someone in all these categories and you've probably seen this. So my final parting words for you on this is, on the exam, if they ask you, what is the typical cognitive issue with a 88-year-old female, right? You might think of your grandma, right? Or if they ask you, what would be a normal response for a 3-year-old toddler, right? You could think of your 3-year-old toddler child or nephew or niece or whatever. So try to, on the exam, don't just throw your hands in there and like, oh God, I don't know, I don't remember that chapter. Be like, no, okay, I know Harvey, right? My 3-week-old nephew. Okay, yeah, he cannot roll over on his own yet. So that's normal. So what I'm saying is just try to think of someone in your family or friends or someone that you've encountered to try to stumble your way through these questions if this so happens. So with that, that's all I have, and I appreciate y'all's attention.